All right, this is, I deal with this a fair amount of the time in the neuro ICU and status epilepticus. So that's a seizure where the patient does not return to neurologic baseline. And the diff includes subtherapeutic drug levels, abnormal chemistries, the sodiums are the big culprit, like I mentioned earlier. Drug toxicity, the quinolone example that I mentioned earlier, alcohol withdrawal, we see a lot of that, unfortunately. Other encephalopathies, hypoxic, ischemic, anoxic events, HIV, Alzheimer, and hypertensive encephalopathy or PRES. So meningitis, sepsis, encephalitis, cerebral mass lesions, tumor, abscess. AVM is arterial venous malformation, which is just a bundle of high-pressure arteries connected to low-pressure veins without the pressure decrease via the capillaries in between, and head trauma. All right, here's our Ativan again, fosphenytoin, Keppra. With persistent seizures, you can reload with fosphenytoin, you can reload with Keppra, and then if they are still persistent, this is where we have to put them down, so we intubate them, and propofol, phenobarb, or pentobarb, in addition to continuous EEG. And we have 24/7 epileptologists or seizure doctors over at the U that will monitor the continuous EEG and call us if there's any seizure activity, and then it's up to me to titrate these medications or add more medications. And then at the bottom, there are other accepted algorithms for treating status. Juvenile myoclonic epilepsy, not really an emergency per se. I'll just go over it quick. Idiopathic primary generalized epilepsy starts around age 15. They get myoclonic jerks at AM. You know, you'll see a patient, you'll be like, yeah, my arms are shaking or jerking like this. And there's a characteristic finding on EEG, 4 to 6 hertz, irregular polyspikes and waves. This is a patient that would be admitted to like an epilepsy monitoring unit. We have one at the U where they come in for a couple days, they get hooked up to EEG, we try and induce seizures, we localize the seizure focus in the brain, and then prescribe medications for that. Divalproid, lamotrigine, Keppra, Topamax, and Zondervan. We don't use Dilantin, carbamazepine, or phenobarb for headache and migraine. I'm going to skip the migraine part of this, but let's touch on the headache. Meningeal stretching from increase or decrease ICP causes headaches. Meningeal irritation causes headaches from white cells, such as meningitis, bacterial, and viral. Red blood cells floating around in the subarachnoid space irritate the meninges. That's why a person that has a subarachnoid hemorrhage can get a stiff neck and act like meningitis. And some of the time our transfers in from other facilities, that's how subarachnoid is actually diagnosed, is they were going down the meningitis pathway, they got an LP, and then a plethora of red blood cells. We do a cerebral angiogram and find an aneurysm. The meningeal ischemia, such as temporal arteritis, and then meningeal sensitization. There's a syndrome called medication-overuse. Folks that have migraines, they can have rebound headaches and then primary headache disorders. Primary versus secondary headaches. Primary headaches are considered the typical headache. Bothersome but not life-threatening conditions. It's similar to past headaches. You know, these are migraine headaches, trigeminal, autonomic, cephalogia, such as cluster headaches or hemicrania. The secondary headaches are what are the worrisome finding. They're constant, and folks will say, this is different from my previous migraine. Like, I have migraines, but You know, I was exerting myself, and all of a sudden I had a sudden 10 out of 10 diffuse headache, whereas with my migraines it's retroorbital or in the front or back of my head. This is a red flag. This will prompt you to order imaging and tests. And the differential secondary headache is mass lesions such as brain tumor, idiopathic intracranial hypertension, sometimes seen in women more than men, giant cell temporal arteritis, meningitis, subarachnoid hemorrhage, carotid or vertebral artery dissection, which anytime you have a patient that has a whiplash injury, always think about vertebral artery or carotid dissection. These folks can go on to have massive strokes, and I've actually had patients die from ischemic stroke from dissection. And then medication-overuse headache. When to worry? Tumor, hemorrhage, meningitis, temporal arteritis, CSF leak you're concerned about. Again, first, worst, persistent, or different headache than usual, and then plus minus an abnormal neurologic exam. A good history is key. As mentioned earlier, onset with exertion, sometimes Valsalva or head trauma, new onset after age 50, worsen with head position, and any lack of migraine-associated features should prompt you to investigate further. If the history is consistent with migraine and the neuro exams, normal brain scans and other tests are not necessary. True, but I can tell you that if you go to any ER anywhere with a headache and you say that this is not like a typical headache, or even if it is a typical headache, you're probably going to get a head CT scan. Just some headache mythology. I'm going to skip that slide. I'm going to skip that. So just so you know, Dr. Gordon is a migraine specialist, so he's included headaches in the emergency neuro lecture. And this is a lot. You guys can look over this. I kept these slides in here for your enrichment. Migraine. He likes his migraine. You guys can read over this slide. I'll skip this too because this is talking about migraine. All right. Skip that too. We'll skip medication-overuse. Migraine therapy, we'll skip that. Emergency migraine care. Head trauma. All right, I see a lot of head trauma at the U. We're the only level 1 trauma center in the state. The neuro intensive care unit will admit isolated head trauma. If they're multi-system trauma with the head injury, they go to the trauma service. So we'll admit with neurosurgery on board to help us out. So basilar skull fracture is a fracture at the base of the skull. There are some characteristic findings. You'll have bruised periorbital ecchymosis called raccoon's eyes. You'll have mastoid ecchymosis called battle sign. When you look in their ear, you can see blood behind the tympanic membrane. That's called hemotympanum. And sometimes they can have a CSF leak out their nose, clear rhinorrhea. And to check it, just to make sure that it's not allergy, we can check the sugar on it. We can get a glucometer, and the sugar will be high. That's one way. There's also another test that's a send-off to tell us if it's CSF or not. And then arteria leak from the ear. All right. So this is my bread and butter, so I'm going to spend some time on this stuff here. Subdural hematoma is a closed head injury. It's caused by tearing of the bridging veins It can be acute, subacute, or chronic based on the density of the blood. So acute subdural hematoma is a large gelatinous clot, and depending on how big it is and if it's causing any midline shift or signs of elevated ICP such as unequal pupils, it's an emergency. They're going to the operating room. Subacute and chronic, as the blood breaks down over weeks to months, it liquefies, and folks can have chronic subdurals. This is slower in onset, and it may just be very minor symptoms like mild weakness on one side of the body or headache even. Treatment for that can be surgery. However, there is a procedure that can be done at the bedside. It's a drain placement. It's called a substrain subdural evacuation port system, where the neurosurgeons come to the bedside. They numb up the skin. They make a laceration with a scalpel, and they screw this little drainage system through the skull into the subdural space and drains the blood that way. Folks who are prone to subdural hematoma are older folks that have brain atrophy. So as the brain shrinks, there's tugging of those bridging veins, and those bridging veins can rupture and bleed. Also alcoholics who have brain atrophy are prone to this too. Alcoholics get drunk and fall a lot, so we see a lot of subdurals in our alcohol abuse population. Epidural hematoma, that's an emergency as well. Cause is typically a skull fracture. Typically it's the temporal bone that's fractured, as that's the thinnest bone in the skull. The middle meningeal artery traverses the inside of the temporal bone, and when there's a temporal fracture, that fracture lacerates the middle meningeal artery, and they have an arterial bleed. So subdural is venous, low pressure bleed. Epidural is high pressure arterial. So stands to reason if it's high pressure, there's going to be a lot more blood, right? These are the folks that have what's called a lucid interval, which is they're awake and then they pass out and then they come to again. And if you have that history and they have a headache and they have a head trauma, they need to get to the closest emergency department. Also cerebral contusions, or what we call traumatic intracerebral hemorrhage. We see a lot of contusions which are just brain bruises. The problem is that a lot of the folks that fall and sustain these are on antiplatelet and anticoagulant medications. My last bad cerebral contusion that I had, it was an unfortunate gentleman who required dual antiplatelet therapy for a recent heart stent. He was on aspirin and Brilinta, and that's a horrible combination from a brain perspective, and this guy didn't do so well. So what you'll find is these bruises progressively get worse. There's no real reversal for Brilinta or Plavix. You can give platelets, you can give DDAVP, which is desmopressin, to try and help the platelets stick, but it very rarely works. So, bad thing to have. All right, head trauma evaluation. Someone arrives to the emergency department or the trauma bay, the trauma side of the ER and OU. They're immediately getting a CT scan without contrast after the ABCs are performed. Sometimes we get folks in that need to be intubated right away that are herniating. It's called cerebral herniation syndrome. It's where the pressure in the head builds up to a point where the brain contents shift, and it shifts and torques and twists the brain stem. That's what causes the unequal pupils. That's an emergency. We give mannitol. I'll put a central line in them and give them concentrated salt water, 23.4% hypertonic saline, hyperventilate them, but that's a surgical emergency. So most of the time I'm working right alongside the neurosurgeons as the operating room is being prepared. CT scan is the best to show acute blood and skull fracture, and then MRI brain, that's the best modality to actually look at the brain tissue itself and to look for some acute blood. All right, so here's CT scan, the acute, subacute, and chronic subdurals. On the left there, you see on the left side of the brain, as we're, I think you guys probably know this already, but as we're looking at head CT scans, the patient's in the scanner, the head position, and then picture the body coming out at you. So the right side's up there on the left, and the left side's up there on the right. That is a large left acute subdural hematoma. It's hyperdense, hence white on CT. And depending on how this person's doing, they're getting a trip to the operating room. In the middle is an isodense subacute left subdural. You can see how the blood is much less white, more gray, and sort of blends in with the surrounding brain parenchyma. You can see where that's can be missed. If you're in a facility where you don't have radiologists that promptly read, you do your own reading. But if you can tell, in the middle here, there's a little bit of midline shift. So you look at that and you're like, something's not right here. And then you look at it closer and you're like, oh man, that's a big left subdural. And then on the right is a chronic right subdural that's hypodense. See how it's dark, black. And then there's an acute left subdural, it's hyperdense, so you have multiple density bleeds. CT versus MRI, these are just, this is flare sequence MRI, which just shows blood is hyper intense on that particular sequence, and then the CT is isolated to, excuse me, hypodense, scans from the same patient. All right, epidural. So there's a subdural and there's an epidural here. So this person's had a significant trauma to their head. A is the acute right subdural, and B is a falcine subdural there along the falx. And again, as I told you, tearing of the bridging veins accumulated at a variable rate due to it being a low pressure venous hemorrhage. And then C is actually an acute left epidural hematoma. It's convex, not concave to the bone, but you can be fooled. I've had some epidurals that were actually concave. So I guess more the rule, but just be careful. And then epidural hematomas, it can be any artery in the brain, but it's typically the middle meningeal as it traverses the temporal lobe. All right, cerebral herniation. This is very bad. I deal with this a lot, and there's things to do. The first thing to do is to immediately recognize what's going on. So you see one up there is the falx. You can have herniation across that and shift across the midline. It's called subfalcine herniation. It causes bicerebral dysfunction with altered or depressed level of consciousness. And then the second area of herniation in the brain occurs where number 2, across the uncus, uncal herniation. The herniation actually causes compression of the midbrain. The brainstem does not like to have any insult. So when you have brainstem compression, that is a true emergency. You'll have depressed consciousness. Again, going back to the reticular activating system is in the midbrain and upper pons with projections to bilateral thalamus up. You'll have the different sized pupils due to cranial nerve 3 compression, and you also have posturing. Typically what's called decerebrate posturing, which is extensor posturing. So it's where they do this. This is decorticate posturing, this is decerebrate posturing. All bad signs. You go to great lengths immediately to try and reduce the ICP, and depending on what the lesion is causing the elevated ICP, an emergency trip to the operating room. So with herniation, the treatment is get the head of the bed 30 to 45 degrees with the head straight. And why that is to allow venous drainage from the head. You'd be surprised how much this helps. I've lowered ICP by 15 to 20 points in patients. And normal ICP is 15 and under. We start to get worried if it's persistently above 20. But I've had folks with ICPs in the 40s, and I put their head at 45, put towels on both sides of the head to keep their head straight, allow that venous drainage from the head, and it's worked to decrease their ICP. Intubate and hyperventilate if the patient isn't intubated already. Normal PCO2 on an arterial blood gas is 35 to 45. Here, we want to try and get it to 32 because studies have shown that at a PCO2 between 28 to 32, there's enough vasoconstriction of the vessels in the brain to decrease blood flow through the brain. So there's three things in the brain that we can play with to decrease ICP. There's blood, there's brain, and there's cerebral spinal fluid. So here, we're decreasing blood flow through the brain by getting that PCO2 down to 32. Insert an indwelling bladder catheter because the next thing we're going to do is give mannitol. So mannitol is an osmotic diuretic that decreases intracranial pressure. It works fairly rapidly within 15 to 30 minutes. If they have a central line, I'll give the hypertonic saline instead, and the hypertonic saline is analogous to pouring salt on a leech. You do that, the fluid is pulled out of the leech by the salt, and the leech shrivels up. So, but typically, when a patient first presents, either in the trauma bay or in my ICU, they very rarely have central access. And you can't give the hypertonic saline in a peripheral IV. You have to give it via a central venous catheter. This Decadron is only for tumor edema. We don't give steroids to cytotoxic edema from ischemic stroke. So that's all right, stroke. Three types of stroke. Ischemic stroke, 85%, ICH, 10%, subarachnoid hemorrhage, 5%. Ischemic stroke is usually due to cessation of blood flow from a thrombus in an artery, and then everything beyond the thrombus, that area of brain dies or infarcts. Intracerebral hemorrhage is due to a bursting of an artery within the brain, also called intraparenchymal hemorrhage. We use those terms interchangeably, ICH or IPH. And that, a lot of the time, is due to uncontrolled hypertension. Subarachnoid hemorrhage is a very bad condition. It's due to bursting of an artery around the brain in the subarachnoid space, only 5% of strokes. All right. Acute ischemic stroke equals cerebral infarction. We couldn't get the clot dissolved in time, so the brain tissue dies and is usually a permanent deficit. The number one cause of morbidity in this country is ischemic stroke. TIA is stroke symptoms, but there's no infarction and there's no permanent deficit. The symptoms resolve with time after the clot dissolves. TIAs do signal that the patient is at risk in the future for an ischemic stroke, and that they may not be so lucky next time. Both are emergencies. Both need to be transported rapidly to a stroke center. I recommend Comprehensive Stroke Center because Comprehensive Stroke Centers can do all the treatments, including thrombectomy, which we'll talk about in a little bit. Time is brain, save the Penumbra. I know for years and years and years when I was a paramedic, it was all cardiac. Oh, you know, time is heart muscle, time is heart muscle. Well, time is also brain too. And you want to save the penumbra. So the penumbra is a zone of reversible injury around the core of an irreversible infarct. TPA given within the first 4.5 hours may bust the clot and save the penumbra neurons and improve their outcome. But it can also cause hemorrhage as well. I see maybe 5 or 10% of folks that get IV TPA go on to have what's called a hemorrhagic transformation or hemorrhagic conversion of ischemic stroke due to intravenous TPA. Mechanical thrombectomy. We're doing a lot of these days. There was a study that just came out a couple months ago that said you can do mechanical thrombectomy up to 24 hours post symptom onset, given that they have a salvageable penumbra. A lot of the time what will happen, mechanical thrombectomy is a cerebral angiogram plus clot retrieval procedure. So it's like a heart cath. They access the femoral artery, they put a catheter up into the brain, and then they're able to thread clot retrieval devices, and there's a couple out there in the market, to pull the clot out and reestablish blood flow. I like this at the bottom here. The TPA opens up arteries just like Drano opens up clogged water pipes, but large stubborn blockages may require physical removal, and that's what thrombectomy is. All right, so preserve the penumbra. That's the goal of our care of ischemic stroke patients, because we can't save the core or dead or infarcted brain tissue. So after a few hours, the penumbra either returns to normal brain tissue or it becomes infarction. We love high blood pressure. High blood pressure actually protects the penumbra. So whereas other ICUs in my hospital, the cardiac ICU, the medical ICU, works diligently to treat hypertension, we use hypertension, not only in ischemic stroke, but also in subarachnoid hemorrhage, which I'll talk about in a little bit. So you want to avoid low blood pressure, you want to avoid hyperglycemia. Study after study has shown that there's folks have poorer outcomes with hyperglycemia. You want to prevent fever, and you want to prevent seizure. Rapid recognition is essential, and with that, rapid transport to a comprehensive stroke center is essential in my opinion. IV TPA is only safe and effective if given within a couple hours of stroke onset. Mechanical thrombectomy you can do beyond 4.5 to 6 hours. Again, it's rapid recognition of strokes. And you guys, depending on where you'll practice, whether it's emergency department, whether it's a family practice clinic, wherever, anyone can have a stroke at any time. So, if you have any concerns whatsoever, call a stroke alert and let the neurology stroke team figure it out, because time is brain. These are just the stroke center levels for your knowledge. OU and Mercy, and as I said earlier, I think Baptist and Tigris is trying to go comprehensive. We have thrombectomy, TPA, hospital care available. Primary stroke centers just have TPA available in hospital care. They don't have thrombectomy capability. And then the stroke-ready hospitals, the level 3s, just administer TPA. So these are the hospitals that will do what's called a drip and ship. So they'll give TPA, it's a bolus and then infusion, and then put them on either a ground or air ambulance and ship them to us as fast as they can. This is a busy slide. I'm going to skip this. This is the whole big picture in stroke care. I'll go over it because a primary care clinic, folks that are going to go practice primary care, you have a role in primary and secondary prevention. Secondary prevention means they've already had a stroke and you're preventing further strokes. EMS, ED, hospital, rehab hospital, specialty clinics, back around. There's also a certain subset of people that drop off that die from stroke, especially the large, what we call malignant middle cerebral artery strokes, where their language center is knocked out or they bleed. In my facility, there's a fair amount of people that don't survive if they have a very large ischemic stroke, unfortunately. This is just more. I know Dr. Gordon was very proud of all these bullets all the time. So this just goes through the level 1 and level 2 stroke centers, what they have available. And comprehensive has the angiography suite for thrombectomy, operating room, neurosciences, ICU. So folks that have a large enough stroke will develop cerebral edema. That cerebral edema shifts the brain. So if they're under, the study was done in patients under 60, they'll get what's called a hemicraniectomy, which is where the neurosurgeon will actually take half their skull off to let the swelling do its thing without any brain shift. We've done hemicranies on folks in their mid to late 80s. I don't necessarily agree with that, but that's the neurosurgeon call because it doesn't save their life. You still have all the deficits. It is just to save their life. It doesn't fix the problem. So we try and counsel a family, 85-year-old grandma who's in a nursing home who has dementia. I don't know if we're going to gain a lot by trying to save her because now she's going to be aphasic, globally aphasic, have other problems. She's hemiplegic on one side. She'll be bedridden for the rest of her life. So there are a lot of end-of-life issues that are discussed in the neuro ICU. Make sure you guys have advance directives. I know you're young, but you'd be surprised how many families fight in my unit. We've had I can't say routinely have to call security or the police, but there's heated arguments among family members because mom and grandma didn't state her wishes. So talk with your loved ones about what they would want, and that would save a lot of stress during critical illness such as ischemic stroke. Okay, so this lists providers' roles. If you all decide to go into primary care, prevent your first stroke, so that's control blood sugar, blood pressure, weight, lipids, pre-hospital and the emergency department, and the neuro ICU and the neuro intervention guys. Those are the folks that do the thrombectomies. We want to try and preserve the penumbra, prevent complications in the hospital, try and preserve the penumbra, prevent complications, promote recovery, try and figure out the cause and prevent recurrent stroke, and then they go to post-acute rehab facility to promote recovery, and then they're back to primary care. And that's the secondary stroke prevention, and then prevent vascular dementia. All right, so pre-hospital has a large role, even though they don't spend much time with the patient. Getting the patient to the right facility is key. We had a very good outcome a couple months ago. There was a patient down in Ada, and the paramedic crew bypassed the Ada hospital, called the helicopter, and rapidly transported the patient straight to us. Saved many hours, because once you get to an outside ER, there's a bunch of paperwork. Many hours would be lost. The paramedic crew did a great job. This lady came in aphasic and right hemiplegic, which means she wasn't moving her right side at all. They did a thrombectomy. She walked out of the hospital walking, talking, with just very, very minor deficit. So that's what it's all about. In the ER, if you guys practice, it's rapidly identifying, differentiating stroke from stroke mimic, which is a lot. A stroke mimic is someone who's infected or has electrolyte abnormalities. they could cause stroke symptoms, but we do an MRI and they don't actually have a stroke. So you always want to pinpoint the last known well, or LKW. When you guys get out on your clerkships, you'll see that in a stroke patient chart, LKW, last known well, because we need to know last known well for the timing of thrombolysis and thrombectomy. And then call a stroke alert. At OU, it's called a stroke alert. Other places, code stroke, code gray. We want to keep the penumbra neurons alive. As I said earlier, we can't do anything about the brain or the neurons that have already died. So we want to keep the penumbra alive. So we don't lower blood pressure, we don't administer glucose solutions, and we want to keep them normal thermic, prevent fever. And then again, the TPA and the mechanical thrombectomy for penumbra reperfusion. All the comprehensive stroke centers have a protocol. It's 24/7. We've really seen a significant increase in stroke alerts with the change in time to performing thrombectomy up to 24 hours. We get a lot more strokes flown or driven in from other parts of the state. At the bottom, this just talks about who all responds or who is notified of a stroke alert. The neuro ICU will take care of these patients, and we're also notified as well of the stroke alert. So, folks with strokes, with ischemic strokes, are at risk for aspiration, so keep them NPO, which means no pros, nothing in the mouth. All of our stroke patients are evaluated by a speech-language pathologist for a bedside swallow exam, plus minus a dysphasiogram. It's a barium swallow down in radiology to see if they're aspirating. We don't put Foley's necessarily in initially, but if they get bad, then obviously we do, because we need to monitor urine output. Stroke mimics, ICHs, we see this a lot. There's a stroke alert paged out, 10 minutes via ground ambulance. The ambulance actually wheels the patient to the CT scanner and then takes them off their ambulance cot onto the CT gantry in the CT scanner. A lot of times, the main stroke mimic we'll see is ICH, intracerebral hemorrhage. Obviously, we're not going to give any thrombolysis. We cancel the stroke alert, and then I get called and say, hey, can you come down to the ER? We have an ICH patient that needs to come to you. So, tumor with bleed or seizure, we see that every once in a while. Because we have Stevenson Cancer Center, we have Neuro Oncology. We do see a lot of tumor and GBM patients. And some of the time, they'll have seizures, or that tumor will bleed, and we'll get an abscess, subdural hematoma, old stroke, brain lesion with either partial seizure in post-ictal state or reactivated by toxic metabolic insult. Old strokes can actually reactivate, and you can have symptoms years later, and we'll talk about that more. Also, other stroke mimics, hypoglycemia, partial seizure, migraine, aura, somatic symptoms, which is another term for psychiatric issues. And most commonly fool us are the migraines, seizures, and old strokes that have reactivated. And there's been more than one person that has received TPA for migraine. Stroke recovery and reactivation. So this is an interesting phenomenon. New brain cells can form around the stroke damaged area, and they're not as resilient as the neurons we were born with. As someone either gets sick, or they're fatigued, or they drink alcohol, or they take a new medication that sedates them, they can have these neurons function not properly, and they can have a reactivation of their old deficits, such as weakness, aphasia, that may mimic a new stroke. Just remember that no one has the same stroke or TIA over and over. So if a patient has the repeat spells that are always the same, either it's an old stroke temporarily reactivated, seizures from an old stroke, or a migraine. In acute ischemic stroke, high blood pressure is a good thing. Arterial occlusion causes high blood pressure. We don't want to lower the blood pressure, as stated previously. Sometimes we may need slightly lower the blood pressure if we're going to get TPA with cardine, IV calcium channel blocker, below 185 over 110, and then post TPA it's 180 over 105. So, and this is just what I just mentioned. There's the cardine again. There's the pre and post TPA blood pressure parameters. And then Dr. Gordon, who's also a strokeologist, does not give TPA or perform thrombectomy if the blood pressure is greater than 220 over 120. Pre-hospital emergency department again. Don't allow aspiration pneumonia. We're going to do all that stuff like I mentioned. TPA, there's the last known well, given within 4.5 hours. Earlier you give it, the better the outcome to try and reperfuse a penumbra. About a 5 to 10% symptomatic ICH risk. No upper age limit. You can give if taking warfarin, but their INR has to be less than or equal to 1.7. Give it if the patient has persistent moderate deficits. There's the dose. You give it via 10% bolus with the remaining 90% over 1 hour. Absolute contraindications are on the left. Relative contraindications are on the right. I'm going to try and move a little bit faster because I want to touch on some other stuff beyond these slides here. Just know that the high blood pressure is good in acute ischemic stroke. Again, get TPA only if you can lower BP safely to 185 over 110. Here's the artery territory infarcts on CT. Red's the middle cerebral, blue's anterior cerebral artery. The yellow and black shaded posterior cerebral, and then the checkerboard is the anterior choroidal artery. This is MRA of anterior and posterior circulation. This is distal versus proximal M1 segment occlusions. So subcortex will also catch the leg, given the homunculus, how that's given. And the M1 causes only face and arm weakness. The beginning of the M1 causes face, arm, and leg weakness, same as distal ICA. So you can localize the area of the lesion initially by just potentially doing a quick physical exam. Left hemisphere syndromes, left MCA infarctions with CT exam correlations. Small artery occlusions are subcortical. You can have right hemiparesis, right hemisensory loss, both face, arm, and leg. Typically not thrombectomy. Cortical infarction, you'll have aphasia as the language areas are affected. You'll get gaze preference, and it looks to the side of injury. You'll get a right visual field deficit, right hemiparesis, right hemisensory loss. Beginning of M1 occlusion, possible thrombectomy. You'll have aphasia, gaze preference, visual field, and hemiparesis and hemisensory loss. Right hemisphere syndromes, you get neglect. Subcortical, you'll get the left in hemiparesis and hemisensory loss. With a right MCA M1, end of M1 occlusion, you'll get neglect of left side of your body. And subcortical and cortex, you'll have the neglect, but you also have the leg involved because the subcortex is involved. So. Ensure last known well within 3.5 hours. Perform the stroke scale. Pre-admission Rankin scale. That is a disability scale that we use You know, if a person has had prior strokes and they use assistive devices or they're bedridden, we take that into account if we're going to give TPA or do a thrombectomy. You're checking a blood glucose to make sure they're not hypoglycemic. You're getting non-contrast head CT. And CT angiography is a CT scan with dye. If they're allergic to dye, to iodinated contrast, you can do MRA without. We're doing a 12-lead EKG in all the labs, as I mentioned about earlier. For a thrombectomy greater than 4.5, we're doing all the same things. And then CT perfusion. I want to touch on this briefly. CT perfusion, we've been doing that about a year. The core and the penumbra. So the core is dead brain. Penumbra, as you know, is salvageable brain. With CT perfusion, we can see the penumbra and, hey, let's get this patient to the cath lab because they have a large penumbra. That's a large area of brain that we can save. So you can see that's pretty much the entire left MCA territory penumbra. So this person is emergently going to cerebral angiography for clot evacuation. Three most common etiologies: large artery, athero, hardening of arteries in the neck and brain due to vascular risk, small artery disease, LeCun, infarcts or lacunar infarcts due to hypertension and diabetes, and then cardioembolic. Folks that have AFib or abnormal heart rhythms have a clot form in the heart. It's ejected with a heartbeat and goes and lodges in the brain. There's also non-atherosclerotic vasculopathies and hypercoag states, common in children and young adults. And then there's the watershed strokes, the hypoperfusion, the sudden drop in blood pressure, the sprinkler picture we looked at earlier. This is a summary of ischemic stroke. I won't go through this for the sake of time. This is a slide about what we do days 1 and 2 after stroke. They get an echo to look for clot in the heart. They get obviously head CT they've already had. They get MRA, head and neck, get an EKG, plus minus hypercoag workup. That's blood work. All right, intracerebral hemorrhage, bleeding into the brain tissue due to non-traumatic vessel rupture. I see a lot of hypertensive ICHs in my ICU. It's chronic, uncontrolled hypertension, damages the small penetrator and perforator arteries in the medial brain, which include the basal ganglia, the caudate, putamen, the thalamus, the pons, and the cerebellum. Obviously, you don't want a big bleed in the pons because remember the reticular activating system is there. You're in a coma. You don't wake up. I have a unfortunate young woman who is probably deceased by now in my ICU I took care of when I was last on service. 39-year-old hypertensive patient abusing methamphetamine, came from a rural Oklahoma hospital with a massive pontine hemorrhage. She's never going to wake up. Life Share was involved, and hopefully some good can come out of this, and they'll be able to use some of her organs. Some of these. Non-hypertensive ICH, we see this in older demented folks, and there's a condition called amyloid angiopathy. Amyloid is a protein that is usually cleared from the brain, but as we age it builds up and deposits in our arteries and weakens them, and then over time weakened artery ruptures, and they can have massive brain hemorrhages. Also ruptured AVMs, arteriovenous malformations, as I talked about earlier, the bleeding tumors, and then bleeding disorders. Interesting case in my ICU right now. I have a lady with a factor V deficiency. She's 73. She has had a spontaneous subdural hematoma. The incidence, I think, of factor V deficiency is like 1 in a million, and this was her first episode of abnormal bleeding at the age of 73. ICH score, we use this to prognosticate. The higher the score, the worse off they are. 1 to 2 is good, 3 to 4 poor, 5 to 6 very poor. You see this unfortunate person here on the right has a thalamic, left thalamic intracranial hemorrhage with shift, IVH, hydrocephalus. Interventricular hemorrhage is blood within the lateral ventricles, you can see there. Depending on comorbidities and how old they were, this could be a comfort care talk, or we put an EVD in, see how they do. There is one of our neurosurgeons actually has started to do basal ganglion thalamic hematoma evacs. It's minimally invasive. The device is called BrainPath, and the issue with ICHs is blood's like acid on the brain. It causes a very intense inflammatory reaction, and if you can decrease some of that hematoma burden, there's less edema and better recovery. Emergency management. We want to keep their blood pressure not too high but not too low. We do a CTA to look for dot sign. Dot sign means actively bleeding hemorrhage. So what we see is actually a bright white dot, which is contrast extravasation on the CTA. That can be an emergency because it means that the bleed is still bleeding and it's getting bigger, and potentially off to the operating room right fast. We work closely with the neurosurgeons. They're usually called first, actually, by the emergency department, and we're called second. The external ventricular drain gets put in to relieve pressure. If it's a posterior fossa hemorrhage in the cerebellum, because it's posterior fossa, external ventricular drain doesn't work. The only way to take care of a cerebellar hemorrhage is to take the skull off and suck out the clot. These patients always come to the ICU so we can watch them close. We treat their blood pressure, prevent complications, rehab. ICH score of 3 to 6. These are the folks that we're having a sit down, come to Jesus talk with about has the patient ever expressed any wishes, if they were critically ill, you know, and do they have advanced directives, stuff like that, because it may not end so well. Subarachnoid hemorrhage. This will be my last topic. I wanted to cover subarachnoid hemorrhage because this is a topic that is near and dear to my heart because we take care of a lot of subarachnoid hemorrhages in the state, and it's a condition that you can't miss. A re-rupture of an aneurysm carries an 80 to 90% mortality. That's huge. So if you see someone in clinic that has a good story, you have to send them to the ER. I can't tell you how many times I take care of aneurysmal subarachnoid hemorrhage patients where they've had multiple trips to the ER or multiple trips to their PCP, and they get turned away saying, oh, it's just a headache, or you're looking for drugs. This cannot be missed, because if it re-ruptures, the odds are greatly against the patient of surviving. Saccular baryaneurysm rupture is the most common cause of non-traumatic SAH. The most common cause of subarachnoid hemorrhage is trauma, but aneurysm rupture is the most common cause of non-traumatic subarachnoid hemorrhage. Aneurysm is a weak outpouching in the wall of an artery, typically around the circle of Willis, which is the anterior circulation in the brain, comes up the carotids, and then everything bifurcates and feeds the brain. AVMs, tumors, and bleeding abnormalities can also cause a subarachnoid, but much less so than aneurysm. Non-traumatic SAH, as I just mentioned, is an emergency. Find the blood. Just because you have a negative CAT scan of the brain doesn't mean you can still have subarachnoid hemorrhage. A lot of patients that I see that I just mentioned that are initially delaying diagnosis is, well, I went to the ER, they did a CAT scan, they said it was normal. You have to do a lumbar puncture. You have to look for red blood cells and or xanthochromia if they have a good story. And then they're shipped to us, and then we do sometimes we can see aneurysm on CT angiogram, but the definitive test is catheter angiography, cerebral angiogram. All right, there's the circle of Willis. There's most common locations of aneurysm rupture, the ACOM, PCOM, middle cerebral, and basilar is posterior circulation. The vertebral arteries come up through the cervical spine, intracranially form a basilar artery. In chronic hypertensive patients, a common area is tip of the basilar, which is right here, and those are very dangerous aneurysms. Management. So you want to get a good history and physical. If they have a good story, you need to listen to them, okay? And that includes asking them what you were doing. You'd be surprised how many times aneurysm rupture during sexual intercourse. You need to ask about what you were doing, okay? Anytime increases ICP. I have 2 patients in my ICU right now who ruptured during sexual intercourse. Everyone gets all, but, you need to figure out what's going on. Stiff and painful neck, and that's the meningeal irritation. That's the ER goes down the meningitis path. Well, their neck is stiff, and then they do the LP, and there's no white cells, but there's a bunch of red cells. Photophobia, light sensitivity. Also, depressed consciousness, nausea, and vomiting come along with it due to increased ICP from the bleed. Again, find the blood, find the aneurysm. There's a scale we use, Hunt and Hess. We also use WFNS, World Federation of Neurologic Surgeons, scale to prognosticate. And treatment, you need to prevent rebleeding. That's why rapid diagnosis is key and transfer to a facility that can obliterate the aneurysm, because as I said prior, a re-rupture carries an 80 to 90% mortality. Manage complications. As the red blood cells break down, here's the grading scales you can look at quick. As the red blood cells break apart, chemicals within the red blood cells and hemoglobin is a big culprit as well, causes what's called vasospasm. Vasospasm is just what it says. It's a clamping down of the arteries in the brain. So this person has had a bleeding type of stroke, and then they go on to day 4 to 21, and they become at risk for the ischemic type of stroke. Because if you picture, if you have the blood vessels clamping down, there's going to be ischemia. So we do daily what are called transcranial Dopplers, which are ultrasounds to look for blood flow velocity. Physics principle, blood flow velocity is going up. We can deduce that there's arterial narrowing, and then they need to go to cerebral angiogram to see if the arteries are actually narrowed. If they're narrowed, they can give intraarterial vasodilators to relax. Here's a good example on the left of a basilar tip artery. See that huge circle right there? That's a monster basilar tip artery. If that thing were to re-rupture, man, that would be devastating. And then coiling is where they actually put titanium wires that actually coil and ball up in there to obliterate the aneurysm. And you can see the coil mass on the picture on the right. So treatment to prevent Valsalva, you obliterate the aneurysm, clip or coil. If I had the choice, if I had an aneurysm, I'd want a clipping because that's permanent. With coiling, you can have residual aneurysm where you potentially would need further coilings or procedures down the road. Nimodipine is a calcium channel blocker that's in one study partially funded by the drug maker showed a delay or a decrease in delayed cerebral ischemia or the vasospasm. These folks stayed 21 days in our ICU. There's a vasospasm like I mentioned earlier. Sometimes we treat with hypertensive therapy, like we actually give them pressors to keep their blood pressure up. If they're in vasospasm and the arteries are narrowed, we need a higher blood pressure to push blood through the narrowed arteries. We do the transcranial Dopplers daily, the ultrasound I just mentioned. These folks are on prophylactic seizure meds. Keppra is what we use. We must prevent hyponatremia. These folks that have brain problems, not just subarachnoid hemorrhage, but brain trauma, brain tumors are at risk for what's called cerebral salt wasting syndrome, where they drop their sodiums, they become hyponatremic. That's detrimental because that can cause cerebral edema and worsen their situation. So sometimes we put these patients on saltwater drips. Hydrocephalus, I alluded to prior, the red blood cells clot off the area in the brain where the CSF is resorbed, and then they get an EVD. A lot of these folks also have NSTEMIs, non-ST elevation myocardial infarctions at rupture, because it's such a huge stress on the body. And it looks like I've run out of time. This is just vertigo, which it really isn't an emergency per se. However, you can have, with brainstem and posterior circulation dysfunction, you can have vertigo. So always remember, is this a brainstem problem? And then also spinal cord problems, which we'll skip over. Cord syndromes, stuff like that. What questions do you guys have? I know that's really heavy stuff, especially at 3 p.m. on a Monday. You guys have been here all day. Yes, ma'am.
I have to remember it. So the watershed strokes, how come those were under the bicerebral damage? Because isn't that just one area of the brain?
It is. It is. I think Dr. Gordon put it there just because you can hypoperfuse. When you hypoperfuse the brain, you're potentially at risk for having a watershed infarct on the other side as well. So that's just where it tacked it in. So. All right. Well, I hope to never see you guys in my ICU because I think something bad has happened. If you guys are interested in rotating, Dr. McNeil, I don't know how that works. I know I take OU students, but you guys go where? Mercy Baptist?
We also are at OU.
Oh, yeah, okay. Okay.
But mostly throughout the state.
Okay. Okay. I know that someone told me that St. Francis in Tulsa has gone comprehensive stroke center as well, so they would have a neuro ICU with the ability to care for all these conditions as well. So, sorry I ran out of time, guys. A lot of material, but if you have any questions, please reach out to me, and I wish you well.
Thank you.
Thanks,